Welcome to Ask Dr. Mingle, the Q&A series for Mingle Health, answering your questions about quality programs and the transition to value-based care. I'm Dr. Dan Mingle, family physician, founder, and CEO of Mingle Health. A quick reminder before we begin, you can always send us a question on LinkedIn, YouTube, or email us at hello@minglehealth.com. Joining us today is Laura Dietzel, a key member of the Mingle Health Clinical Informatics team. Welcome, Laura.
Hello, Dr. Mingle. Thank you very much for inviting me here today.
Delighted to have you. I invited you today to help us understand the challenges you find facing our ACO clients intending to submit either Medicare CQMs or MIPS CQMs for the APM Performance Pathway, or the APP. Tell us a little bit about what you do on the clinical informatics team at Mingle Health.
So probably one of my primary tasks is helping our clients, ACO clients, with the acquisition, evaluation, and the processing of the data that they're going to use to report the quality measures. Our team is able to leverage many years of working with many different systems, both on the billing side and on the EHR side of the workflows, to help clients both leverage the data that they currently have to report CQMs, as well as developing additional data sources, improving their data governance, and their data readiness for reporting quality measures.
For our listeners out there, I'm sure most are aware of this, but what is the timeline now as it pertains to the APM Performance Pathway, that is the APP?
Right. So 2024 is the final year that ACOs can report quality measures using the web interface method. In response to that deadline, many ACOs are engaging Mingle to help them start to report either the traditional MIPS CQMs or the Medicare CQMs, or in some cases, we're being asked to help ACOs evaluate their readiness to report one or the other. And so we see some ACOs jumping right into reporting, and some are evaluating ability to report while still using web interface for this, their final year of web interface reporting. So we see really clients using a variety of approaches to this final year of investigating readiness, either starting to report or evaluating readiness to report quality measures in this last year before they have to transition away from web interface reporting.
Thanks, Laura. And what data does an ACO need to successfully construct a good APP submission?
Yeah, there are two data sources that we look for. First are the claims data that needs to come in from whatever billing system in whatever form. We can take flat files or 837 files, but those are the two kinds of products we look for from the billing systems in all of the member practices. And then we look for clinical data that comes from the workflow out of an EHR. So we look at all the various systems. We look for either flat files, QRDA files, any kind of extract that can help us get to that numerator data that helps clinics avoid manual chart abstraction and the cost associated with it.
So, Laura, you mentioned two kinds of data, claims or billing data on one hand, which I think you're telling us is a source of denominator data, and then clinical data. Let's break them down a moment. Tell us more about the claims data. What is it? What do we look for in it? And where do our clients usually find that data?
So if you look at the specifications for each of the three ACO measures that are being reported for quality, the denominator for those measures, the population that is being evaluated, is defined by a set of CPT and ICD codes. And those codes come off of the claims data, either a flat file, 837, whatever the clients can produce, either from a vendor product or from a billing service. So we can sort of fluctuate wherever the data can be found and work with those sources. And we typically find, again, like an 837 or a flat file, and from that data, when we ingest those claim files, we create a denominator for each of the quality measures. And then the next step is to look for the numerator data that will come from the clinical systems.
Now, what is an 837 file? Is that something that that a client has to generate out of their system, or tell us where that comes from?
Sure. So an 837 file is a national standard that has been created for the collection and submission of billing data from the practice to the payer. We're able to leverage those files by way of creating the denominator for the three CQMs that we're reporting to CMS. Whether an 837 or a flat file, these files are available from your billing system or your billing vendor. So they're not a unique product that is needed, that you need to create to submit quality data for the CMS programs. They're already available, and however you're submitting that data to your payer is the same product that we can use for creating the denominators for the quality measures. 837s, flat files, either ones will work equally as well, but they should be already available within your system by way of however you're billing to your payers.
Can you give any tips, Laura, for how our clients end up finding those? Do they have to go on a hunt through their systems, or what are the resources they can use to get access to these?
So typically there are products within the practice management system that are designed for exporting billing files, either flat files or 837s. So those same products that are in the billing system to send the data to the payer is the same products that we'd use to grab that same data and use it for the quality reporting. It should be readily available either from your system, your practice management system, or the vendor that you're using. They create those billing files to send them on your behalf to your payer. And so we ask clients to take those same files, copy them to us, and we use those files to create the denominator for the three quality measures.
And let's move on to the clinical data moment. What are the typical sources of clinical data that our clients discover and send to us?
So there are three ways that clients typically report numerator data. The ideal way is by leveraging whatever structured data comes out of the workflow into a structured field in an EHR. And that way we can just pull that data and use that to calculate a numerator. The other way that clients are reporting measures is through claims codes or QDCs, quality data codes. These are non-billable codes that can be included on the claim. And if clients have been using those or would like to use those on an annual basis, maybe for the annual wellness visit, collect a couple of codes from that process, that can also help report numerator data. And finally, the most manually intensive approach and the most expensive approach to reporting the numerators would be through manual chart abstraction, reviewing the chart, putting the responses into a product that we provide, and then we can use that data that's been manually collected to calculate the numerator. So those three approaches are typically what we see.
Thanks, Laura. That makes a lot of sense. Now, when we engage with a new client to create a quality submission for them, and they start looking for their data, what are the common surprises that they're running into? What are the common challenges?
A number of challenges, I think, are really surprising our ACO clients. Probably the first or the most predominant surprise are the restrictions of a contract, either the contract with the vendor, the EHR vendor, or even sometimes restrictions within the ACO membership, who can see whose data, or the EHR vendors may have restricted what kinds of data the clients can extract from their systems. So it's contract limitations that are starting to show up in some of these conversations. And so we need to sometimes go back to the table, get partners to talk to each other, come up with new agreements by way of exchanging data. Sometimes clients will need to renegotiate vendor contracts so they get access to more data types, more data extraction, or extraction tools. That's one thing that we're seeing as a kind of a surprise to vendors or to clients who are working with the process of collecting numerator data. Another challenge has been the volume of the data. So one of the measures, especially measure 134, the depression measure, has a very broad denominator. Most of the encounters in an ambulatory care environment are going to qualify for that measure. So I think one of the other surprises clients are finding is the sheer volume that they are finding reported for these three measures. And when you're thinking about if you do have a data gap and you are reporting 300 patients for a quality measure versus 3,000 patients, that data gap can really translate to a lot more manual effort to report the quality measure. So just much higher volumes than might have been expected. That leads to much higher than expected chart abstraction costs to collect all the data needed for the meeting the reporting rate or meeting a performance goal.
Now, just a point of clarification for me, Laura. You're describing a lot of different ways of getting this data and the surprises around them. Um, in these complex organizations that are ACOs, do they have to they have to come up with the same way for each of their practices of getting data to us?
They do not. That's sort of the nice thing about being able to work with a registry is that a registry has the flexibility to combine the data in whatever form it's being found in all of these member practices. So for example, if some member practices are very mature have very mature workflows on their EHR product, they're collecting a lot of really good, robust data that they can export, for example, as a QRDA1, that's a great way for us to leverage all of the data they've collected and help them avoid any chart reviews by way of reporting the data. Other members within that same ACO might still be on paper practices, might be struggling to switch from one EHR to another EHR during the year. So registries can really come in and pull the right data at the right time to fully and accurately define the denominator. And the numerator for these clients. So we can use chart review, we can help clients start collecting quality codes in their workflow, whatever they are able to do by way of helping them report to the reporting rate requirement, the data completeness, and also the performance goal. We can work with those goals on the ground.
In your experience working with these larger organizations, what would you describe as the key indicators of success? What makes a difference between those organizations you see struggling with this and those who pull it all together for a successful submission?
Yeah, great question, Dan. And this is one that I have a lot of kind of passion about with regards to helping ACO clients be successful. And that is just data readiness. Really having had some time and the resources to dive into what these three measures are asking for, the data that they're asking about. Certainly, a lot of our clients are ready to dive in and start pulling the data and reporting the measures. But a few are actually even asking, are they able to collect this data on a timely basis across the ACO membership? And so that data readiness piece and that data discovery piece before diving in, I think will help ACO clients best prepare for success. So by data readiness, what do I mean by that? First of all, going around to each of the member practices and getting hands on the data that we need to both create the denominator, the claims data, the flat files, or the 837, getting those actually in hand. Oftentimes we find that members have been asked questions about can you produce, can you send us this kind of data? They feel confident they can, but when it comes down to the rubber sort of hitting the road, again, we've run into contract constraints. You don't have access, client, to pull the data from your system. You need to pay your vendor to pull this data from your system. They're going to be the delivery body or the person who's going to do the reporting. That sometimes ends up being a surprise. So really collecting data samples from all of those data sources across the EHR, making sure you have free access to your claims data, to your numerator data, whatever you can extract from both of those systems is key. And the other piece is just understanding the volumes. Do you understand how many patients are going to be pulled into these denominators? How many records you're going to review? Where your data gaps are with regards to reporting? Understanding the data needed to report these quality measures, its availability, and any gaps in that data will be key to success.
Well, great. That was quite a discussion. I take it that you then are prepared, or Mingle as a company prepared to help our clients however they wish. If they can bring the data together and then bring it to us, that's great. Or if they want us to handle the data directly from the participant and then just give them the aggregate data back, I take it we do both.
We've done a lot of work in the last year to develop a variety of project tools that are specific to this APP program. And one of them are file management tools. If clients are looking for assistance to help organize and manage and curate that data before it is passed to Mingle, to help their membership sort of better understand the nature of the data that they're sending, where there might be gaps in that data. Yep, we definitely are developing a lot of tools to help folks understand all kinds of information about the data they can send, the files they're collecting, and the timeliness of that whole process.
Thanks, Laura. This has been a great session. Thanks for you listeners who are out there. We may easily have. I hope we've generated some thought, given you some good ideas. If we've generated more questions, don't hesitate to ask. We'd be delighted in the future to dig in deeper into any of these things you want to hear more about. Just remember, we just want to be helpful. We want this to be useful to you. Don't hesitate to correct or supplement our answers. Share your experiences. Tell us how you've solved particular problems. Ask your questions. Dig in a little deeper when you want to. We can be smarter together.